So, good afternoon. My name is Philippe Mel, as I probably know that you know my name. And to start, I would like to say that I'm really excited to be part of this webinar series on the All on Four, and to have the opportunity to share our work with you. It's really fascinating how technology in these days is helping us to share knowledge, and for sure this will have a big impact in our treatments in our patients will benefit a lot with that. I can tell you from me, Anna, and Miguel, we are very excited with the possibility of doing this. So, and it's crazy if we look back to 10 years ago, this wouldn't be possible. If you wanted to learn this, you probably had to wait 10 years to you had to not to wait 10 years, but had to wait for a book or something to be published, or even to fly to Lisbon and to be spend some days with us to learn these kind of things. So I'm really excited. So before starting with the topic that I will have during these two webinars, that is the prosthetic part on the Ford, let me just quickly introduce myself and give you my personal and professional background. So um, I live in Lisbon and I was born in Lisbon. Although I used to live in the south of Portugal, and I don't know if you know the city, but the city is amazing. Is with an unconventional beauty and with amazing food. And the our main attractions as a city, although the city and the food, is the Fado. I invite you to come here to visit us at Malo Clinic, and also if you have time to have a beautiful dinner, listening some Fado. And obviously you shouldn't waste your time and try to try this beautiful pastel de nata, a custard tart. They are amazing and you should try them. So I live in Lisbon, and I started working in Malo Clinic in 2005. My journey started just after leaving university. I had the opportunity to come here, and during my first year and a half, I was working in the surgical department with Dr. Malo, and it was crazy times because I had the opportunity to prepare all these cases together with Anna and other colleagues, because we were a group of people, not just me and Anna, and we were preparing all the surgeries and the first steps of our dentalist patients, and not only that kind of patients. And it was amazing because, and I can show you this interview that came out at that time, because during my first 2 to 3 weeks we were preparing our live surgeries, presenting the Nobel Guide concept with All on Four. Can you imagine a young kid with 25 years old in his first weeks at his new job, seeing new stuff coming out, new materials, new implants? It was amazing, and I
E
will
para
show
o
you
caso de
this.
serem dadas cerejas a quem não tem
It's in
dentes, não
Portuguese,
há
you will not
problema.
understand it,
Cirurgião
but
português acaba de conseguir feito clínico.
at that time it was crazy, even in
Não
Portugal,
tarda
because
muito, Armindo de Leão andará nas bocas do mundo. Para já,
our
despede-se de uma
rings didn't
prótese
stop
dentária tradicional
ringing,
que não
our
lhe deixa
phones didn't
grandes
stop
saudades.
ringing
As
during
limitações eram
2 weeks
precisamente
with patients to
nunca
come
saber
and see
quando é
this.
que, por exemplo, num espirro me saltava
And
uma prótese. Uma vez
nowadays,
vi, por exemplo, um colega que num
let me
discurso
just
salta-lhe a
finish the
prótese.
video and I will
Dentro de
continue
minutos terá um
because
sorriso novo. É um passo importante na vida deste homem de 70 anos. Para o Dr. Paulo Maló é mais do que isso. Vai entrar na história da cirurgia oral.
What do you have for us this evening in Lisbon? Well, Patrick, I've got a very spectacular session here for you.
A cirurgia é transmitida em direto para Las Vegas. 10.000 especialistas de todo o mundo aguardavam com expectativa. Já não tinham de esperar muito.
Let me ask the patient if he's okay. Tá okay? Podemos começar? Yes, the patient gives us the thumbs up. So, this is time for rock and roll.
Pela primeira vez, numa única cirurgia, vão conjugar-se duas técnicas inovadoras.
O All-on-4 é uma técnica cirúrgica que permite utilizar osso dos maxilares ao mínimo possível para colocar 12 dentes fixos, que são os dentes necessários para mastigar e necessários para a estética. Neste momento, no maxilar inferior, não é necessário transplantes de osso. Qualquer pessoa que não tenha dentes no maxilar inferior pode colocar dentes no espaço de 1 hora ou 2, fixos, sem se tirar e pôr, dentes como se fossem naturais. E no maxilar superior revolucionou no sentido de que a maior parte também consegue fazer a mesma coisa. Pode morder. Morda. Mais à frente. Ok. Morda com força, está bem?
Nesta cirurgia, a técnica All-on-4 é combinada com a Teeth in an Hour, que é como quem diz, dentes numa hora. Antes da operação é feito um taco ao paciente, é criado um modelo virtual dos maxilares e a cirurgia é simulada em computador. A partir deste modelo é criada a guia cirúrgica e os dentes que vão ser implantados.
Tudo o que nós temos que fazer é colocar a guia cirúrgica na boca do paciente, colocado naquelas zonas,
let me just go ahead. And basically this was a news flash in the biggest journal in Portugal. And we were presenting Nobel Guide in Teeth in an Hour, and at that time, more than 10 years ago, we were already doing some digital stuff and delivering one immediate bridge in less than 20 minutes. So I was very young and not it was so many things at that time that I didn't have the knowledge to understand what was going out there. But it was quite disruptive because just to think that we were doing immediate loading at that time, delivering bridges, it was really crazy. So, and if you can see that at that time we were still doing some cases with bone grafts, and I was seeing all that happening. Some patients had to do bone grafts, and other ones no, and seeing Nobel Guide and the impact that Dr. Malo had on the lives of these patients was quite important, and it still is, because nowadays everyone the All-on-4 is it's quite famous and predictable, and everyone is using. So, and that's the reason why we are here also, to share our knowledge with you. So after that time in the surgery department, I started in the prosthodontic department, where I evolved as a clinician and where I am still today, and where, besides doing rehabilitation with dentalist patients, I also evolved doing minimal invasive dentistry. And in recent years, I developed interest in other fields, such as speech therapy and jaw functional orthopedics. And basically nowadays, my main goal is to share our protocols and also bring some awareness on the functional aspects of our oral rehabilitations, and try to put the same functional aspects and aesthetic aspects in the same bag, because I see that is the one of the keys to the success of our rehabilitations. So I always start my lectures telling a personal story, and basically on Sundays my family prepares us a lunch, and to gather all the families, the way that we find to get all together. And in one of those lunches, my grandmother, she used to live in another city outside of Lisbon, and she came to us. She already passed away, so But at that time, it was very shocking for me to see that when she was talking with one of my brothers, the way she was talking, the way during the lunch, the way she was eating, I was very observative at that time. I was studying some stuff, and and it was interesting to see um, how being an dentalist patient affects you so much in your daily life, and how this can compromise not just your aesthetics but your behavior. Um, and it was funny that later I went I went to her and we talked a bit and we discussed these things. And she told me that for her it was okay because she didn't have the opportunity to know what was to be with to have a rehabilitation with implants. The dentistry at that time didn't had this kind of treatments. And if we look nowadays, modern dentistry um, is is going wow. We are trying to to look at nature and being inspired by the nature and copy that. And basically it's what inspires us as a clinicians. We go to social media and we see beautiful stuff being made. We are really copying nature. And my view on a dentalist patient is that this kind of patient should have the same inspiration. We should bring the same energy and effort to rehabilitate the dentalist people. And more than that, I also nowadays think that when we rehabilitate the dentalist people, that we should be conscious of another stuff. And this is my main goal, what to share with you, is that we should look obviously for the static thing of the rehabilitation, but I want you to start thinking from today as a concept of reorganization. And to do that, I think that we should have a thorough understanding of the elements that compose the natural dentition and the way that they distribute on the oral environment. And with that, we should also know the causes and consequences of the loss of these elements until the total edentalism. We also, we also should be aware of the situations where we should privilege a rehabilitation with, or a total rehabilitation, let's say this, or a mixed rehabilitation with teeth and implants, a mixed rehabilitation. Because sometimes we have to decide that, you know, that you are on the edge. What should I do? What should I not do? And we should understand that when we should go for a dentalist rehabilitation, because that for sure will help the patient. And that knowledge, that expertise should be channeled into a clinical approach, so that you integrate the elements, the artificial elements with the rehabilitation. Because the all-on-4 basically is that you you remove teeth, you remove bone, you reduce gums, you put implants, and then you will substitute all these natural elements with artificial material. And this is very important, just not because of the aesthetic reasons, as I'm telling you, but also because of another things, and we will discuss these things. And one thing that I also like to comparison that I always like to do is imagine yourself when you were 30 years, and when we still feel young, besides being adults, is that we are okay with us. We, for example, I did braces. We are okay. Yeah, you start to lose some hair. At that time you feel not so okay, but okay, let's go. But as the time goes, okay, your skin also starts to change a bit. You some white hairs, and your teeth start to be a little bit yellow. But you okay, maybe I can do some things. But when you lose your teeth, it's just not a thing of aesthetics. It's something that you cannot change. Something more happens. Um, you your behavior starts to change. You start to adapt. You start to be not so good when you talk with people. And the reason behind this is losing all our teeth. It makes a compromise on our facial harmony. And the reason behind this facial harmony is the facial support. And when we go to an all-on-4, we basically we want to regain this facial support by regaining that lip support. And the reason behind this, let me just go through this, is a specific resorption pattern of the bone, as you know. That's why when we see edentulous people, we see them like Popeye with the chin up. And the reason behind this is because the bone in the upper jaw goes up and backward when that resorption pattern occurs. And in the mandible, what happens is it seems like it goes forward and backwards. So you end up like this. And if we go to a frontal aspect, we also have something similar, because in the mandible, if you see on your right side, I believe, in the mandible looks like it goes down and does this, and in the maxilla it goes up and goes inside. So we have to have this knowledge when we are rehabilitating our patients, because this will influence the position of our teeth. And one of the key aspects, and I believe Anna told you about this, is regaining the lip support. Is one of the main aspects to achieve success in these cases. And we will do that not just putting the teeth on the correct position, but also devolving our patients the alveolar crest with artificial material. Another thing that is very important is the transition lines that we will be creating between the artificial material and the natural tissues. And this is critical for success, because we don't want to see the transition lines. If we see the transition lines, this will compromise our goal. And I think it's very easy to understand when we see this in the frontal view, but I think it's quite difficult to understand why the lip support is so important. So, and why they are both critical for the bone reduction. Okay, to cut bone just to avoid transition lines on the frontal aspect, I think is very clear. But when we need to cut bone because of the lip support, we need to understand, if we don't cut too much, in the end, when you want to place a prosthesis, you will need to avoid prosthesis with more than 45 degrees on that platform. Because if you have more than 45 degrees, you will compromise the comfort of the patient, his hygiene, and even the smile. Because patients that have these kind of things, they develop an horizontal wrinkle on the upper lip. And this is very important, and we want to avoid this since the beginning. And this is why the all-on-4 is not a procedure that ends in the surgeon or the prosthodontist. Is a multidisciplinary approach that starts in the first visit of the patient, and it goes through the surgery, the lab procedures, and even the follow-up with our hygienists. And even we want the cooperation of the patient, because this is a teamwork. If the team doesn't work, our goals will not never be achieved. Okay, so this is critical that you have this in mind. So in our perspective, in the rehabilitation of a dentalist patients following the All-on-4 protocol, in the vision of a rehabilitator like a prosthodontics, we always divided the the rehabilitation in three different stages, each one of them with three representative elements. If the immediate bridge is the first stage and the element that is supposed to reduce the discomfort and anxiety associated with removable dentures, the second provisional is that element where we put all our efforts to achieve the patient expectations. And when we achieve that, we want to go to the third stage, just copying the result from the second provisional and just giving more resistance to that bridge. This is the mindset, this is the workflow. So, and during my lecture, I will go through these stages and discuss some things about each of these stages. My goal today is to go through the immediate bridge, see some things that in our approach to the patients, and even go through some possible complications after this and during the first 6 months. Later, I will go to the second provision and a final work, and in the end, wrap up with some new stuff. So, okay, so let's go to the immediate bridge. As I told you, if we look back, when we used to do second stage surgeries, the idea was so that the patients would take a removable denture during the cicatrization or osseointegration phase. And the problem with this is that removable dentures have an uncontrolled loading of the implants, and this was compromising the quality of our implants, and some marginal bone losses and implant failures. And on the other hand, the possibility of doing immediate loading reduced a lot this kind of discomfort, giving more function to the patients, and with a more positive impact on the patients after this kind of procedures. And not just that, with immediate loading, you reduce one surgery to the patient. So it's our approach to the patient is it's faster. So it's very important to understand why what immediate loading gave us on the rehabilitation of a dentalist patients, and basically is that. And how should we start with this? What do we do at Malo Clinic normally? So imagine a patient that comes to All-on-4. So you need to make decisions. And as Anna told you, you need to make decisions directly to surgery and others that are concerning the prosthetic part. And I will show you more or less how we basically organize the visits of the patients in the clinic. So imagine that a patient comes for a first appointment for a rehabilitation plan, and normally just with an OPG we talk with the patient, we decide the possibilities. But if we feel that the patient really wants to do, we need more information, because we need some volume bone. We need information from the volume to decide which kind of All-on-4 we are talking about. And so on that first appointment, we do that. Because after that, we also need to give a budget to the patient so that he can understand the implications of the treatment. And basically this is the first appointment. If the patient decides to advance to these kind of things, we normally have an oral hygiene appointment before of the surgery and a treatment planning appointment. And this treatment planning appointment is where we, from the prosthetic part, we enter. So, and where we review all the medical story with some questionnaires to the patients, and we start to collect information and how we should do that. So you need to have a protocol, a photographic protocol to your patients, and basically OPG, CT scan, and picture. See the importance of this, because normally if you go to an operative room at Malo Cleaning, we have the CT scan printed, the OPG printed, and the pictures printed just at the side of the doctor that is operating. So this is very important, and we are always touching on this. You need pictures to decide where to cut bone. So in that protocol, you need to have pictures with the patient smiling, with and without prosthesis, so that you see where the gum is. So you, and to so you that you decide where you should cut the bone. And you should also have pictures from your sagittal view, with and without a prosthesis, so that you decide the influence of how much you should cut to avoid prosthesis with 45 degrees, more than 45 degrees. Another thing that you should see, and as I told you, the bone reduction, another thing that is very important to understand, we don't need to cut bone just because of the lip support and the smile line, but we also need to cut bone to get space for the prosthesis. This is very important, because sometimes if the information is not well digested, let's say like that, you can end up with a bone reduction that is not so okay. So, and imagine, if you see in the picture, you need space for the teeth, you need space for the titanium frame, and you need space for the gum. So on total, you need from the incisal edge until the last part of the bone 15 millimeters. So, okay, we already have the information of the CT scan, we have information with the pictures, and we have information with the OPG. Okay, now we need to decide what? We need to decide where we should place our incisal edge. So, and this is another thing that you should address since the beginning. So you don't need to look only to this kind of cases, looking only to the bone. You need to also to understand your limits. So 50 millimeters at least on the frontal aspect. And when I tell you the concerns about bone reduction, is normally people, when do the surgery, they concern a lot on the frontal aspect, and they don't have idea how the new occlusal plane will be. And we cut bone like this, because you are cutting the bone like this, and then you don't have idea how the new occlusal plane, and sometimes you end up with short spaces on the posterior part that can compromise a little bit our end result. So just to have a picture of this, when we don't cut bone, see the implications on the picture on the left of not cutting bone and having to work out a prosthesis with teeth and natural gum, and on the other side a prosthesis that has gums and teeth at the same time. So when we don't cut bone and when we try to use natural gum, we are a little bit compromised to achieve a natural look. And even we are also compromised in achieving a nice shape of the teeth, because they all need to be like this. and even the axis of the teeth, they all need to be like this. So they need to be square with no papilla, and so this is not so good for in our view. And when I was telling about the bone reduction, if we don't cut the bone and in the end part, we could have some limitations, and then at the end is more tricky to finalize the cases. So our goal is to since the first day to try to have the most information possible to make our lives easier at the end, so that we don't need to improvise so much in the final part of the rehabilitations. Okay, so if we need to decide where our incisal edges should be, we should get another information, and one thing that we should consider also is age, and the age and the size of the upper lip. And in this study, Vig and Brundo, they did a nice survey, and they compared the lip with different ages, sexes, and races. And one of the biggest conclusions that they saw was that with age, we expose less the upper teeth, and we start to expose more the lower teeth. And this is, for me, is quite important, because you need to give the patients, obviously you can give a more younger aspect, but you shouldn't be so extreme, because normally the tendency is, for example, in an old patient is to give high exposition of the upper teeth and forget the lower ones. So, and this is very important that you have this in consideration, to adapt your rehabilitation with your patient, with his age, his race, and everything. And so, and this study is very interesting. I recommend you a lot to read. Um, and here you have a little bit a resume of that part, but we will not go deeply in this. And another thing that is very important, and I think is one of the most critical things when we want to improvise, it's the occlusal vertical dimension. Because if you want to put the incisal edge where you want, you also need space for that. And so you need to address the vertical dimension since the beginning, because it will decide the amount of space that you have in the mouth, and which amount you can raise so that you display your new teeth in the right position. And there's lots of ways to go through that. But normally we go simple. We just compare the height from eyes to lips, and then from here to here. And we write this down on the clinical record of the patient. And this is very important since the first day. And one thing that is very important, you can't lose an idea of the vertical dimension when you are doing the all-on-4, because you need to go to the vertical dimension that you want, and you can't lose control. That's why we always print, we always do not print, we always do a mark on the nose and on the chin before the surgery starts. Because, and you will see some image and some videos and with that, because you always need to go to the vertical dimension that you decided. So imagine a patient that came to you, an dentalist patient that was wearing a total denture, and when you compared the vertical dimension, you saw, I need to raise the vertical dimension at least 10 millimeters. So you write this in his clinical record, and before the surgery starts, before the anesthesia, you do the marks. And then you do the anesthesia, you do the all-on-4, you do everything, When you start to do try-ins and the bite registration, you go to the vertical dimension that you desired. Okay, so if you had 60 and you want 10 more, you go to 70 and it's okay. And you control that during all the procedures. Another aspect that is very important to consider is how you will deliver the immediate bridge. Because if you go to PubMed and you do a small research on PubMed, you will see different techniques to convert the prosthesis. Some of them cemented, some of them just a pickup. There are lots of ways of doing. One thing that is very important for us, we want to deliver a screw retained prosthesis. We don't cement them. We screw retain. And the way we convert prosthesis, it's very interesting because I think we already done more than 10 ways of converting prosthesis. And one thing that for me resumes everything, it will always depend on the patient and what you have in your clinic. Depends on your environment and in your patient. So, and even in Malo Clinic, as you know, we have clinic in Lisbon, we have a clinic in Porto, Algarve, we are in many places. And depending on the availability of the patient, if he's nearby, even the clinical case, you will need to decide which is the best for you and your patient. Okay, ideally you should have everything prepared because it's faster and it's more predictable, but sometimes you need to do in a different way. So I will address some ways of doing it. Or if you have any doubts, you can write. I'm looking to some questions that I'm receiving. So, and in the end, I want to go through that questions, and basically it's that. So one of the ways that we use to do our immediate bridges when the patients don't give us time to prepare nothing, it's doing a bite registration just after the surgery, and immediately after this bite registration goes to the lab, and they will do everything. And what you will need, you need to, after surgery, to do the impressions. The lab will give you a wax rim, and you will need a pin and silicone to do this. You will see a short video to understand this and to have a clear idea. And how do you do a pin of this? I don't know if you work with Nobel Biocare products, and we work with this kind of products, and you will use an impression copying with acrylic all around, and with this you produce a pin. And normally we use two, and we do a small indentation on one side, and we screw retain this, and we control the vertical dimension. So I now will show you more or less how you do it. So imagine the situation of an upper All-on-4 where you will screw retain the upper wax rim, and doing a bite registration in this case is not a big rocket science. You just need to control, as I told you, the vertical dimension, and after that give information to the lab. As I told you, need to give information from the lip support. If you can't reshape the wax, you can draw lines of the upper lip, you can draw some lines where is the midline. That is very important, and even the canines if you feel that is necessary. And if needed, sometimes a little silicone bite on some parts that you feel that gives more stability to the wax rim. And later sorry, and in the case of bimaxillary case, you will just need to control the vertical dimension. And with this, you need a vertical pin. And imagine that you screw retain the pin or two pins, you control the vertical dimension, and you check with a ruler the vertical dimension. And if it's okay, it's okay. If it's not okay, you need to put more acrylic. Or if it's not okay, you need to cut a little bit the acrylic until the desired vertical dimension. After that, you do a big roll of silicone, you place in the mouth, and you do the bite registration. 1 or 2 hours, not 2 hours because 2 hours is too much, 1 hour later, you should have a try-in. And in the try-in, you try and see how it goes, if the occlusal plane is like this, and you give some idea. Normally we have lab technicians with us, so this is quite helpful in this environment, as I told you. For us, as we are a clinic that is designed to do these kind of things, we have lots of technicians too, and they are working just with us in that day. Okay, so that technician is with that surgery, so he's there for the bite registration, he's there to see the try-in, and he goes immediately to do the try-in so that we are faster. And in the end, as I told you, we want to deliver a screw-retained prosthesis. Normally with 10 teeth in the most of the cases, but sometimes it's possible to do with second molar. But the rule of thumb would be no cantilevers. No cantilevers. So let me show you some pictures of a case where we can see more or less the pictures from before and some things from the surgery and the prosthetic part. So as you see in the pictures on the left, you have the smile line. You see that we need to address that amount of bone so that we don't have the transition lines visible after the end. And the surgery was made, and this is how we produce the wax rim. After the surgery, you do impressions, and we always do impressions. And the reason behind this is that you should have always a box of the patient with his work and with impressions from the day of the surgery at the beginning. Because if something happens, your life is easier, and you will be able to resolve the complication in a really faster way. And to do the wax rim, as you see, you use acrylic and wax, and in the end you will deliver this to the patient during the bite registration record. See, you will control the occlusal plane. Normally we use a Fox plane to check this, and we draw the midline, the upper lip, for example, and see on your right side the pins with an indentation. And one thing that is very helpful for the lab technicians is that you place also a annealing cap on the posterior implants on the lower, so that the silicone also is stable on that part. And see, and this is how we do the bite registration. And I will show you a video so that you understand how it goes, because I think picture helps, but the video even more. So you screw retain on the two anterior implants, it's enough. You will need to check the occlusal plane. I think in this video it's not possible to see that, but you need to see how it is and to address it. If possible, cut the ideal occlusal plane, because this will help a lot the technician, and you can draw the midline. And later you use that pins. One thing that is good is when you place the acrylic all around of the pins, you always will end up screwing the same position. So it's okay and that's what we want. And later you place the silicone, and you try to guide the patient and ask him to bite. And see, we control the vertical dimension with the ruler width, and if you see the marks on the skin, they are there. And you have the pin, the silicone in the pin. Let me just stop a bit. Let me see if I can go there so that I can show you. See, you have the marks of the pins and also the healing caps, and with that it's enough so that they can stabilize in the models, and you have the mark of the occlusal rim. Okay, and later you will do a try-in, talk with the patient and decide what is better to change if necessary. And as you know, if you do a very good bite registration, if you give the information to the technician, if he's by your side, this will help you a lot and you will be faster. So it's very good to have a good communication and strong relation with your technician. And this is why we talk about team approach, because you want in this is a rush in these kind of days, because the patients are waiting, they start to feel bruised, and it's not good to be so much time in the clinic waiting for something. The ideal situation is to deliver the immediate bridge faster. And as you see, in the end, after the approval of the try-in, we deliver the immediate bridge. One thing that is also very important for you to understand is that we don't pressure too much on the first day, because sometimes the patients don't have anesthesia already, and we don't want to damage them so much. So normally we don't pressure the gum on this day. Okay. So this was the situation of one patient that didn't give us time to prepare the surgery. So now let's consider another possibility, and imagine the situation of the patient that comes 1 week before of the surgery. And this is already very good, because you can look at the case and you probably can do more than just trying. And what you will do is you will do normal impression, take the pictures and everything. If possible, do a bite registration. In this case, I placed a wax rim, but you find a way to give the models to the lab technician so that he can articulate the models perfectly, give information where you want your midline, your occlusal plane, and let's see a video how they prepare this, because you need to prepare the models. See, a bite registration. And imagine I was with this patient today, and I did impressions, I did a bite registration, and the technician will um, articulate the models, and together with the pictures and everything, um, we will prepare a removable denture, so that in the end we can convert these prostheses in the mouth. Sorry. Thank you. So yes, we have the articulated models. And now one thing that is very important, we need to simulate a bone reduction. And in this case, it's not very specific. We just reduce one amount. And with some wax, we will start to prepare a base where we can start to do a setup of teeth. Okay? Okay. We prepare a base, and we check if it's okay. And then, as I told you, what is one of the we also one thing that is very important that I didn't talk to you, it's also in the first appointment that we do, we choose which type of teeth we will use it. We use normally a Rausch-Kulzer Mondial, um, and we decide which color and which type, if you want square teeth or oval teeth or triangular teeth, and that normally depends a little bit if it's women, if it's men. For women, normally we go more to rounded teeth. If it's a man, we go to square teeth or more rectangular. And obviously the color depending on the patient. And we address this with them. And as you see, our technician is setting up the teeth, and she started with the two upper incisors because it's where we have more information. If you look back to my 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 lecture is saying about the position of the lip. What we want to give to the technician is the position of the incisal edges. And with the first incisal edge of the 11th, for example, it's enough because you have midline and you have occlusal plane. Almost with that information is enough to set the rest of the teeth, and with that is enough to do a prosthesis where we can do a training and then convert. And normally then the lower just follows the the other one. And now, having the setup, she's just preparing to do the acrylization, doing some channels on the posterior part. And this is a way of doing it because we do it in several ways. That's why I'm also showing you. And basically with some silicone, we will do a wall on and protect the position of the teeth. Okay, we do a first wall and then we do another one. Basically you have two layers of silicone, one that gives you more precision and another one that gives you strength on the silicone. And this is just a faster way of doing it. Okay, as you see, you have a silicone wall, and now you can start to prepare the teeth. And you need one thing that is very important: you need to clean the teeth, remove all that wax, because if you don't do it, and you will see later, sometimes this is one of the complications that we can have with the prosthesis. So, okay, you clean the teeth with hot water to remove the wax. And another thing that is very important, you need to remove the polishing. So you need to unpolish the teeth so that they glue better to the new part of the acrylic. Okay. Now you place some Vaseline on the vestibular parts, and you will place the teeth on each position. Okay, and now you just need to inject the acrylic. Very important also, you need to isolate the models with Vaseline, and you will see how she will do the acrylization. Okay, you see you have that entry points. Now she has the acrylic and the monomer that were prepared in the specific amounts that were predetermined, and she will drop the acrylic until it goes on the other side, and it goes to the pressure pot with some hot water. Okay, and this is, let me go this part, and you remove it. Okay, and now you just have to clean that part. Okay, remove excess, but it's in this way you don't have too many excess to remove. And let me just go forward, and then you need to polish. Okay, and she glued a bit with some wax, and now she just prepares a little bit better the occlusal surface, because in the end we want to place the prosthesis in the mouth, and the occlusal surface, they will help us in the position of the prosthesis. Okay, and this is one nice thing. And another thing that you can do to help us to stabilize is to use a little bit of silicone in the occlusal surfaces, so that in the mouth you have something to stabilize the two dentures. See? And now you just cut it, and we are ready to go. Okay? So in this case, you see the upper prosthesis, you have the palate prepared, and in the lower you have only on the ridge. In this way, on the upper part you have the palate that will help you to stabilize the prosthesis after the surgery. Okay, but as you know, and if you see this picture of a fast all-on-4, in the end the gum was changed. The bone reduction is not the same that we prepare in the model, so it's not always the same position, but it will help you having the palate. Okay, in the end, what you need to do, and while we do it, as we do impressions of the prosthesis, we normally just need to stabilize that two prostheses on two cylinders, and in the lab they will end up the prosthesis. So one way of doing this is to open a hole on the two anterior cylinders, so that you can stabilize with some acrylic. In the old days, and this is an old picture, I really like this picture because it has more than 10 years, we used to have these open windows already, and we would have the laterals and the canines prepared to glue in this position, so that we had already an open window to do this directly, because we knew that normally the two anterior implants would come out around the canine and the laterals. So in the lab they used to prepare us already like this. Nowadays we don't do it so much, but what we do, we prepare the holes, we alleviate the position of the posterior, and then we stabilize it in the model, and we place some acrylic on the two anteriors. We do the impressions, as I told you, and in the lab they fix that capture cylinders in the model, and then they will place the new cylinders on the posterior part and replace the new cylinders on the anterior. So this takes a little bit. So let's see how they do it, because seeing a video is better than just explaining, and talking with a computer is also very strange, because I don't know if you are following so correctly. So you place the replicas, and then you will place a little bit of gum silicone. You prepare the cast, and you will prepare our first model of the patient, because later we will do another one. So because this model, as you see, if you are observing clearly, we use putty to do the impression in the mouth on the day of the surgery. We don't use light silicone because it will go to the sutures. So we just want to stabilize the replicas, the impression copying, sorry. And then we do the model, and this model is very important because you will need it always that is needed. So you prepare the model, and as you seen, we place the upper removable denture, we open a window, and they receive that prosthesis. Let me check. Sorry, let me go there fast. Let me go there. Here. Oh, sorry. I want to pause. So let's start from here, and I tell you. If you see, the upper denture has 2 cylinders only, and we will screw that to the new model and clear the other part, remove the flanges and the palate, and transform that removable denture in a horseshoe prosthesis. And we will use also the bite registration, that when you do upper and lower, you do a bite registration so that they can confirm if everything's okay, and do some better adjustments on the occlusal. And we will articulate again the model, and this articulation will be always in the box of the patient, so that in case that we need to do something, we always have the models articulated. Okay, let me just go faster. This part is clear, I think. See, you have the cylinders, and now you just clear the path to position the other cylinders. Very important, you need to cut the cylinders in the correct height. And now you just have to capture the cylinders to finalize the prosthesis. You need to remove the other cylinders because they could have some blood or something. I already have some questions here. Later I can go back in some slides and be more specific on some things that I'm being asked. Okay. And now you place the 2 new cylinders, and we do later the same thing on the lower. With the gum placed, we will reline the base of the prosthesis because we need at least to contact the gum. So we will need to place a bit of acrylic on the bottom. And it goes to the pressure, to acrylization, and let's go. And now we See that pins is to protect the screw exits. It's very important also, and we need to finish the bottom part. Okay, now one thing that is very important in this phase, or in all phases basically, is we don't want concave shapes on the bottom of the prosthesis, because they will accumulate some debris. So we want you to design the contact of the artificial gum with the upper gum, with the natural gum, in a plane or convex shape. Okay, because that will help you a lot. And see, in the end, you have the prosthesis, and I think we have a final image here, because as you've seen, we have molar. Um, we have molar in the upper part, and we will not remove the molar we left in this case. Okay, only the lower part we don't have the cantilever. Okay, and this is the finished immediate bridge. So this is a way of doing it when you have the patient some days before of that to help you and to design what you want, so you can decide which kind of teeth you want to place, and it's not in the same day in a rush, so you have more time to prepare. The one con of this is you still waste some time after the surgery, because you need to do the impression, you need to wait at least 1 hour from the stone cast, so that they in the end do this kind of lab work to finish the prosthesis. So at least 2 hours, okay, to deliver the image bridge, at least. So, but let's consider another way, because I don't know your reality, and this is very important, and I'm trying to give you solutions so that you can do this with your patients. Another way of doing it is preparing everything chair side, and I will show you a small video, two videos basically. One is how you can do it by yourselves. I normally show these kind of videos in our education programs, because we normally have some hands-on where you can try this with us, and I will show you a way of doing it, how to reline a total denture on the upper arch, and how to finalize the prosthesis, simulating a bit how you can do this. So let's go, and I'll go faster in some parts if necessary. So imagine that you have an upper arch and the upper denture. So you will need to see if it's okay, and then you need to decide where to open the holes. In this case, the prosthesis is already with some holes because it was already prepared. But what we normally do, we place the healing caps. We use some silicone in the base of the denture. And we will reline the prosthesis in the mouth. We will see the correct plane of occlusion and see the position that you desire. And you will have something like this. Having something like this will give you the position where you need to open the drill with the drill, the prosthesis. And what you need is you need to have a clear way so that later you can inject some acrylic on the base of the prosthesis. Okay, so let me go a little bit faster here. See, you need to open, and then you need to go again and try within the model. in the model in the mouth. Okay, so it seems okay. So and now you need to switch from the healing caps and place the cylinders. Okay, and you will screw the cylinders, and you need to have some protection on the cylinders to so that the acrylic doesn't go in, and you will check again if it's okay, because it needs to be clear. See, I want you to have a clear open part so that the acrylic goes all around the cylinders. And now you need to cut the cylinders. We normally cut them before. We don't cut them because we want to use the patient mandible to stabilize the upper prosthesis. If you don't cut the cylinders, this will interfere with the bite, and you will need to stabilize just freehand. So, and we don't want that. So you'll need to cut the cylinders. So, and normally I do some marks, as you see, and with the carborundo disc you will cut the cylinders. Okay, you cut them one by one, and you check again if it's okay. One thing that is very important, and is the reason why I'm using these pins, is to protect it's to protect the screw from the acrylic. Later, if in the mouth you will not be able to use the pins, so you will need to use some cotton pellets or something different to protect the screws. Another thing that you should have in mind is that we will be relining acrylic in the mouth with sutures and a big amount of acrylic. So normally we use a rubber dam. You don't need a full rubber dam. You just need a square. And in the mouth you will design where you want to place the or open the holes. You will open the holes in the rubber dam. Okay, and to help you also, we will do a small incision on the posterior part so that you can have more flexibility of the rubber dam during the relining process, because you will use the pellet the pellet to stabilize in the mouth, and basically is that. Okay, and this is how you should have in the mouth without the pins. Later you will check again if it's okay. See, open view, protected gum. And what we'll use to inject, we will use a syringe with uh, a tip, not so thick tip and not so thin enough to have some flow, the acrylic, and you will mix the acrylic without bubbles, without nothing. You will check its consistency, and when it's still a little bit liquid, you will protect the tip and place the acrylic in the syringe. You will wait for that and slowly go up and during this phase you need to control the thickness. If it's too liquid, it's still not good. You need to inject when it's with a good consistency, not too liquid and not too stiff, because you'll need to do too many strength, and you will start to inject on the holes around the cylinders. Okay, you will do this one by one. See, okay, and I think it's easy to understand. And then you wait a bit. Okay, in the end, if you want, you can use a brush to place a little bit more, but this is normally in the mouth. We just want to remove it and finish outside. So you remove everything, and now you just need to fill the gaps and prepare the bottom part of the prosthesis, and considering that you want a plain and smooth part without convexities. So to help you, you will place some replicas on the bottom. Okay. You will place the acrylic, wait, and now you just need to cut to create that shape that is traditional in this kind of bridges, in a horseshoe. Okay, and I just for the task I design it, and you start to cut it, and in the end you still have some concavities, see, and you need to address this issue. Remove acrylic that is a little bit upper. Okay, so you, and sometimes you don't need to head, you just need to cut, because you need to have that part that is a little bit rounder, and in the end you need to polish. So, and this is how you do it chair side. But doing this, I will advise you also to do a model, because you will need the model if the patient has some kind of complication. Okay. Basically, is this in a practical way. Sorry. And now, just to finalize in this part, let's see a little faster video. So you need to do the impression. Even doing chair side, you need to do an impression. And one thing that is very, very important is to splint the impression. You need to splint the impression. In this way, yeah, I normally prepare to use a wax, to use a floss, but normally in the surgery they use like this. You see, we use a putty soft to do the impression, because we just want to pick up the splint. We just want that the impression copings are stable and they don't move. And considering the option of using a chair side, we need to use this bite registration. Let me just go not so fast. We need to use this bite registration in this case, for example, to stabilize the prosthesis, and we will check the vertical dimension. Sorry. We will check the vertical dimension, and if it's okay, we are good to convert. And we use the silicone again to know where we need to open the prosthesis. We go to the bite registration, we check the vertical dimension, see, and we will open. And in this case, we used the new impression copings of Nobel Biocare, And with this kind of cylinders, you don't need a screw. You just need to place them, and they get stuck there. Is the new cylinders with the new multi-unit abutments, and this makes it easier when used in this approach. Okay, now you mark the rubber dam, you place it, you place the prosthesis, you inject the acrylic, and in the end you remove the prosthesis, check if everything's okay. And one thing that you can do also is to inject from the upper part, so that is faster, the part. And you in the end you convert, as I showed you, you convert the prosthesis. Sorry, the video goes. Let me go here, because this part is very important. So to deliver, normally place a little bit of chlorhexidine, and we will check your occlusion. And obviously your occlusion is very important. And one thing that we want, we want contacts, normal contacts from canine to canine, and we want to alleviate the posterior part. As you see, the paper is passing through on the posterior. And then in the guidance, we don't want strong guidance, so you need to alleviate the guidance. Okay, you want the patient to move freely the mandible without big canine guidance, with nothing. Okay, and we want occlusion from canine to canine. On the posterior, you alleviate a bit. Okay, it goes to contact, but not strong contact. We want to protect the posterior part, and this is more or less how it ends. Okay, so to wrap up a bit this part of the immediate bridge, and I have some questions regarding this. As you've seen, all the techniques that we use, they are dependent on your capabilities of placing that. And if we look to the upper arch, to correctly placing that removable denture in the correct place. You need to be aware if the occlusal plane is okay, if the midline is not canted. And so this is tricky. It's tricky because you will reduce bone, and it's even trickier on the lower aspect because you don't have the palate to stabilize so much. So it's tricky, and this is the reason why we use second provisionals, because we know that in the first day we will not be able to give full comfort, maybe full aesthetics, and we will not for sure give full function, because as you've seen, we are removing some contacts on some specific parts and removing some guidance. So one thing that I would like to advise you is to address properly the expectations of the patients on the first days. Don't promise prosthesis that will be amazing on the first day. It's a process. And that's why these 3 stages and these 3 prostheses, this kind of rehabilitation, normally the patients have big expectations because some of them know that this will change their lives, for sure, and changes lives. For sure, you know this, but do it in a constructive way. Don't promise too much, because if they think that in the first day will be here and in the first day you finish here, you start to have problems in the first day. So expectations is key to in this in All-on-4. You need to manage correctly since day one. Okay, so this is very important. And one thing that is very important also to understand is, for sure you will face some obstacles in the way after the first day in the surgery, and I will show you some things and how to manage this. And one way of managing, as I told you, you need to have impressions, because if you don't have the impressions of the patient, sometimes you need to do you need to repair the prosthesis in the mouth, and it's not so good. So if you have the model, you can do the repair by in the chair side, but it's way better to have the models articulated so that you can do that faster and in a cleaner way. Okay, so regarding the fractures and complications, the main reasons of them are excess load, for sure, sometimes in parafunctional habits or even prematurities. But one thing also that is important is to consider the lack of passivity. That's why you need to splint the model. And that's why if you want to do chair side, you need to do it correctly so that the cylinders are in the correct place and everything it's okay. Because if the prosthesis is not passive fit on the day, not only you can have fractures of the prosthesis, but you also can have complications on level of implants. So you need to be take care of this for sure. Another thing that is important, and that's why I'm placing this image, see this clear, not chipping, but loosening of the teeth. This could happen if your technician doesn't polish correctly, doesn't remove the polishing of the teeth, the stock teeth. If they don't remove that with the burr before overcrystallization, sometimes this can happen, and it's a complication because patients start to be aware, and you need to change every teeth if you don't manage this properly. So if you have patients with if the cylinders are not okay, if the prosthesis is not passive fit, you need to resolve this immediately. And this is the reason why our patients, they normally do x-ray immediately after surgery. So we need to see if this is happening, because if the prosthesis is not passive fit, maybe your model was not okay. And if the model is not okay, you need to do another model to do to put the prosthesis passive fit. Okay, so, and more things. So one question that sometimes people ask is if we do any kind of framework in the immediate bridges. We normally don't do it, and because for us the immediate bridge is a protection. We want to protect the most important thing of the rehabilitation at that stage, implants. And we prefer that the prosthesis breaks and we repair it faster um, but we don't want to do a framework in a faster way that if it's not passive fit, or if it has any issue, it will jeopardize our work, and this can be a trouble for us. We want to, the king is the implant in the first days. Okay, so, and I don't know if Anna told you about this, but even sometimes when we are doing the surgery, the bone somehow doesn't allow us to place correctly the abutment. And if you don't see this immediately on the day of the surgery, this could be a extreme complication. So during the surgery, you need to check if the abutments are placed correctly. This is critical. You can imagine the problem of this, because if it's not okay, not only bacteria will go there, you can lose bone, and this could be also one of the main reasons of the of breakage of of the provisionals. So if it's not okay, you do, after doing an X-ray, you place the abutment on the correct position, you recheck, and then you do the impression, and then you adapt the prosthesis. Okay, this is very important. This that slide was not, yes. One another thing that can happen also after some weeks after the surgery is that the gums will change with the cicatrization, and maybe patients will start complaining about some air passing through the prosthesis, and you need to address this, because otherwise they will start to be uncomfortable, and it's, imagine, after 3 weeks 4 weeks they will need to wait more 5 months, and you need to change this with no problem, because we remove the prosthesis all the time. This is designed to be, the All-on-4 is designed so that you can remove the prosthesis. There's no problem with the implants removing the prosthesis. And so you need to address this. You need to realign the prosthesis. And how do you do it? So we use a silicone in the base of the prosthesis, and you will screw retain the prosthesis with that silicone, and this will mark the new position of the gum. You place some isolation in the silicone, and in the older model, the older model, you will inject silicone, and you will place a new silicone gum in the older model. Okay, and with this, the technician goes there and he can realign the prosthesis in the new position, and he needs to polish and then do the lever. This is a way of doing it if you have a technician by your side. If you don't have it, you can do it directly in the mouth. It's trickier because maybe you will, in some parts you will do a little bit more pressure than the normal part, but it's a way of doing it, and sometimes we do it directly if it's a little bit in one place. If you feel that you need to do it in a better way, and if you have a lab, again, this will depend a lot on your reality, if you have a lab working on your clinic, and if you don't have it, so you need to be able to improvise. Okay, and as you've seen, when we do immediate breach, we know that we will need to change some things, and that's the reason why we consider a second provisional. So I don't want to go now deep on the second provisional, and I have some questions that people are asking me, so I want to address them, and maybe then later continue with the second provisional issues and the final bridges, and then we will return again to this part. So let me see, and if you have more questions, please, I would like now to address them. So let me get back to the data, because maybe I was not clear enough how to collect the data. So, and people are asking me all data specifically. So before of the surgery, what you really need to start, so you need information for the surgeon. So you need OPG and CT scan. This is mandatory. You need to know the amount of bone that they have, so that they decide which kind of All-on-4 they want to do. If they go to a full bone volume, that where you can do even all on 6, or where you do a normal all on 4, or even consider a zygoma. So, and in that appointment before of the surgery, you need to obviously collect the clinical record of the patient, and then with the pictures, what I want to give you, you want to have an image of the patient and to decide. First of all, you need two pictures that are mandatory for the surgeon are these ones: the smile line with and without prosthesis, and the picture from the side of the patient with and without prosthesis also. With that, you will understand how much lip supporting you need and how many possible transition lines you will have that you need to cut the bone. And having this in consideration, and always knowing that at least you need 15 millimeters to cut the bone, you will understand, and you will also always go on in a secure way. If you need, and if it's possible, you will cut a little bit more bone. But one thing that is important, and I don't know if Anna told you, is the posterior part of the upper arch. Because you can cut the bone, but sometimes you have the sign as well. So, and that is a limit. You can't cut more than that, okay? But you normally these patients they have lack of vertical dimension, so you just need to cut the bone at least a bit so that you have space there at that part. So but let me go here. So you need, as you see, you need 50 millimeters. But when I was talking about the bone reduction, the only thing that you should have in mind so that you clearly cut the bone in a correct way is that you consider at least the curve of SPIE. If you consider the curve of SPIE, you don't cut the bone more on the frontal part than on the distal part. This is hard to explain here, but normally when they are operating, if you cut the bone just like this with the trim bone, and if you don't follow the curve of SPIE on the posterior, you could end up with that kind of scenario that I showed, where you have little space on the posterior. But that is, if you cut the bone following the curve of SPIE, it will be enough for sure. And one thing that you can give you more, one thing that can give you more space, this is what I want to say, it's the occlusal vertical dimension. You can always play with that. So, and this is the data that you need to understand. You have to have an image of the patient, so that you understand clearly how much height of the face you can raise, because we always raise a lot. You can raise a lot because a patient that lost all their teeth, we did a bone reduction. You clear a lot of space for teeth. So normally it's pretty easy to find the 15 millimeters. Okay, it's not maybe just one case, but a specific case of a class 3 patient maybe, or depending on the cases, but normally it's just a specific case. But if you open the vertical dimension, you have lots of space, and then you just need to decide where you need to design. But there's not a big answer where, because in this way of doing that I'm showing now, this is the basic way of doing it. Okay, later I will go further, because now we will discuss how it is the second provisional, and then we will address another ways of doing it. But just to start, because this is a 2 webinar series, I want to understand more or less the protocol and how to deliver immediate bridges and which information is mandatory so that you start thinking in this way. So to the surgery, you need bone volume and a clear idea. So you need OPG, CT scan. To the prosthetic part, you will need pictures of the patient to understand the patient, a clinical observation, and some notes, obviously. You need to decide which type of tooth you will use. And so for now, we have a picture of this patient. I see the face and I consider that I will use oval teeth and I will, in A1, for example, I will write this down. I see that she has a big lip. Maybe she doesn't, is with her natural teeth, she's not showing too much. So, and I will discuss this with the technician. See, she has too much lip support. For example, this last lady, for example, the lip is a little bit too much in the front because she used to have some crooked teeth on the anterior that was giving too much lip support. So you need to write these things so that in the end, when they are preparing in the model, or even when you cut the bone and when you do a wax rim, you give again these informations. But basically is that. But as you see, I'm here at 5 minutes trying to explain which information, but basically the information, how should I do the teeth, but it will always end up in this. This first stage is tricky. And this is what I want to deliver today to you, is if you just consider an immediate bridge and then go directly to a final bridge, it will be trickier. That's why you need to address this in the second stage so that you improve some stuff. It's very difficult because you should collect the biggest amount of data that you feel that is necessary. But even with that, you probably end up with some issues, because imagine the situation of you did a good clinical diagnosis on the vertical dimension. You were very good. You will be very good deciding which teeth the patient wants. Everything was good on the trying before of the surgery. Everything was good. But then when you are relining, something happens, is not so okay, and you failed with the midline. You failed in your occlusal plane. So it's quite difficult in the first day to deliver the bridge, even collecting the biggest amount of data. So in the end of the immediate bridge, what we want, at least that the surgeon does his better work, cutting the bone where is necessary and placing the implants and delivering a prosthesis that at least gives a nice aesthetics and comfort so that the prosthesis doesn't fall, because we need to put this in comparison with the second stage protocol surgeries. But yes, nowadays we can also do better because we have digital ways of doing it, and we will address this a little bit later. Okay, but in the basic protocol for all, because I don't know to whom I'm speaking, the experience of each one of us, but yes, I started the video with a noble guide procedure that we did 15 years ago that was breakthrough at that time and inspired us to change things. And see, after 15 years we are still not doing all the all-on-4s in the digital way because it's quite difficult to overstep some things regarding the bone reduction in a correct way, delivering the prosthesis in the correct way. Nowadays, it's already possible, and we are already trying some new stuff that we will be sharing, I think, in the next months. So, and basically, is that I don't know. People are asking me how to understand the correct plane of bone reduction. Doing like this with little information, I can say that maybe it's not so precise. It depends a lot on the experience of the surgeon. That's why it's mandatory to have a good training to do this. Um, but if you followed Anna's guidance regarding this, I think she was already very helpful regarding the bone reduction. But you need to understand where you will place your teeth for sure, and always cut a little bit more. It's what I can say to you, and protecting that posterior part. Um, the digital way, I already explained that for sure, that it's possible nowadays to do this in digital way, with some guides where you can place some guides, giving the positioning of the implants, giving some guides where you can cut the bone, and some guides to deliver and screw the prosthesis in the correct way. Maybe in these days it's not open to everyone, and we are not using still to every patient. We are still on some tests to see which things are better, because it's a tricky part. You need to decide which printer is the best, which software it's the best for doing everything, because some of the softwares don't allow you to do everything. You need to use open source softwares to finalize some things. But we are in a good way to have some things, and I think in the future we'll have some news regarding the digital way. Okay, I think I'm good for now, but as I told you, expectations is key in this part. During the immediate bridge, we it's very hard to have everything addressed aesthetically, functionally, and comfort. So that's why we will address these things on the second provision. That's where we touch base all the issues. And another thing that you should consider in your part is, please check your reality, what you have around you, or find a technician to work with you so that you are able to do these cases. I I know that sometimes you can ask a lab technician to do these kind of things in your clinic. Just you should just have to need a space so that he can help you, because it will depend not only on the case, but it will depend on your patient. So um, Malo Clinic Lisbon, for example, is not an example because we can do it in many ways. Sometimes a patient comes and he wants to do the next day, so we do it on the slowest way with the wax rim, but it's a way of doing it. That's why we always share this way, because we need to give solutions to you, and I hope that I'm helping you with your patients. So for now, we end up with this webinar, and we will continue with the rest on the next Wednesday. Okay, thank you very much. See you next Wednesday.